Hi, so I'm here with Dr. Shin Beh from UT Southwestern's Department of Neurology. Thank you for joining us today.
Pleasure.
And your expertise is in vestibular disorders as well as migraine?
Dizziness, yep.
Dizziness, okay, unexplained dizziness, right?
All causes.
Okay.
Most of it are migraine.
Well, you're officially known as the Dizzy Doc, especially on Twitter, so you can look him up as the Dizzy Doc. You're also one of the very few doctors out there who's confident to diagnose this illness. How did you get into treating vestibular migraine and other vestibular disorders?
Started off, I think, med school. Okay. So, I found the, patients with vertigo, patients with dizziness more fascinating. They have very unusual eye movements, and then based on their eye movements, you can often tell what's going on. And so that caught my interest at first. And in residency, I found that, a lot of people don't like to see the dizzy patients. They freak out, they run away from them. And so, that caught my interest too. I think it's the masochism related to it.
Really?
So since everyone was running away from it, I decided to explore it more.
Okay.
And so, looked into it further and found that, hey, you can actually treat a lot of the conditions that, present with dizziness, that present with vertigo. You can, bring a lot of relief to a lot of the conditions. And so, then I went into my fellowship training, I went to Hopkins to work with David Z.
Okay.
He is one of the top ones, the gurus for vestibular disorders in neurology. And, through there, learn more about it. When I came back, I started off 50% multiple sclerosis, 50% dizziness. But then as time went by, so there's a much greater need for dizziness and decided to focus on it. Vestibular migraine caught me by surprise, actually. Initially, I didn't expect there to be that many patients. So, while just seeing patients with vertigo and dizziness, I found that more and more had migraines, and more had, it was related to their migraines. And so, decided to focus more on vestibular migraine since we don't know much about it.
Interesting.
Yep.
Well, that's quite a journey. Well, I went through 6 or 7 doctors and was told I had everything from depression to anxiety to a perilimb fistula before I found you. And you have quite the wait list. Why do you think it's so hard for patients to be diagnosed correctly?
I think it's because of the effort that it takes. So you need to get a good history from the patient. You need to know what you're asking. You cannot just go and ask a patient, are you dizzy, are you spinning, and be done with that. You need to take a detailed history from the patient. You need to spend the time and examine the patient. The answers are not in your MRIs. The answers are not in any test. It's all, taking a good history, doing a good exam, and then coming up with the diagnosis. So the effort, the time that it takes, I think, unfortunately, a lot of physicians, they cannot spend that time because, clinics are busy, a lot of hospital settings are very busy, so they don't get to spend that time to really figure out what's going on. And, another problem is also the teaching in medical school. We don't really learn a lot about vertigo, dizziness in med school. I teach the med students in UT Southwestern, and a lot of times I find that they have no previous exposure, even in the clinical years, not much exposure to dizziness, not much exposure to vertigo, and so you have to educate them about how to diagnose patients, how to treat patients, what to look for.
Okay, interesting. Do you think as you teach a little bit more, there will start being more doctors out there who become interested and who know more?
One would hope.
Okay.
One would hope.
Is this something that's specific to UT Southwestern, or are you seeing it more in other areas, other practices?
What, dizziness?
Yeah, or like just a focus on dizziness.
Very few places have it, unfortunately. The big ones in the States would be, at UCLA,
okay.
Johns Hopkins, Case Western, where else do we have? Mayo Clinic, of course, Arizona, and Barrows. So there are not many places that focus on it, unfortunately.
Interesting. Okay, well, what do you look for when diagnosing a patient? What if a patient does not have headaches? I personally don't get a lot of headaches with my attacks, so I think it was hard to be diagnosed when no one understood that sometimes migraines can maybe come without headaches.
Absolutely. So I explain to all my patients, and not only patients, but physicians as well have that question. If you don't have a headache, can you still be diagnosed with vestibular migraine? And the answer is yes. If you look at the different studies in vestibular migraine so it's between 25 to 75% of patients have some consistent relationship with their attacks and a headache. But you don't need to have a headache to have the diagnosis of vestibular migraine. Within the ICHD-3 criteria, all you need would be either the light sensitivity and sound sensitivity, the headache, or the visual aura. So if any of the three, together with the vertigo, the dizziness, or the vestibular symptoms, you can make the diagnosis of vestibular migraine. So although you don't have a headache, but if your attacks of vertigo come with light sensitivity, come with sound sensitivity, you have vestibular migraine.
Interesting. Is there any kind of other tests that you perform? Or I remember like one of my first appointments, you kind of had me looking at the blinds with the lines, and you were like, oh, that's telltale vestibular migraine, just with the fact that I couldn't even look at them.
That's more for to torment you.
Oh, okay.
But bring some important questions. So, like busy patterns, anything like, for example, the carpet, for example.
Yeah.
Patterns like that typically aggravate patients who have migraines, especially those with vestibular migraines. Okay. So, generally, personal experience, most of my patients who cannot look at the blinds tend to have vestibular migraines.
Okay.
Those that look at the blinds without any problem generally don't have migraines.
Interesting.
So, just a little screening tool for me personally.
Yeah. Do you have any other special screening tools like that?
Not specifically. No.
Okay.
No,
okay.
No, not specifically.
Well, you mentioned the IHS, and this is
Yes.
an international body that sets diagnostic criteria for migraine, and it classifies vestibular migraine as an episodic syndrome. But they say that there's more research needed to classify it as a chronic disease. What do you find in your practice?
So half of the patients I see have some form of persistent type of dizziness. They're dizzy all the time, but superimposed on that, they have attacks of vertigo with migrainous type of features. So in those patients, I draw a comparison to chronic migraine, where patients have migraine most days of the headache rather, most days of the month, but on top of that, they have attacks that are consistent with the migraine. So in the same way, patients with vestibular migraine can be dizzy most of the time, and on top of that have attacks of vertigo, dizziness with their migraine symptoms. Another thing to bear in mind is a lot of migraine patients also tend to be a little more dizzy than the normal population. So like, most migraine patients, in the grocery store, they find it uncomfortable, it makes them dizzy, the blinds again.
Yeah.
So most also have that. So having that type of dizziness, can also be considered quote unquote a chronic condition, especially if it affects how you function on a daily basis. So yeah.
Okay, very interesting.
It can be episodic, but it can be chronic.
Do you think they'll eventually change that to be classified as chronic?
Possibly.
Okay.
There's so many similarities with migraine headache. So eventually you could see the same type of classifications.
Yeah, that would be interesting. Do you think that the idea that it's episodic or classified as episodic, and they say, oh, it can last for 72 hours, do you think that puts the patient at a disadvantage for diagnosis if they're having symptoms constantly?
So it depends on who you're seeing.
Okay.
Right? So if you draw that strict 72-hour line there and say, if you have symptoms lasting longer than that, you don't have vestibular migraine, then I think you're being misled. I think the ICHD criteria are useful for research studies. So if you're doing a research study, you of course want your patient population to be, more quote unquote pure. So if you're looking at vestibular migraine, they have to fit a certain form of certain criteria so that the study results are more accurate. But when it comes to treating a patient clinically, I don't rely on that distinction so much. So I don't say if you have dizziness or vertigo lasting beyond 72 hours, I won't treat you as a vestibular migraine patient. I won't treat your migraines. It's something else. No. So those criteria are useful for research, but for clinical practice, I think it's more to the discretion and the wisdom of the physician.
Okay.
Yeah.
So it's just kind of hard to put us in a box.
Correct.
That says
Yeah.
this is exactly what it is.
Absolutely. I mean, I saw a patient, when was it? Yesterday.
Mm-hmm.
So, the patient has a history of Meniere's disease, even had a nerve section, so basically cut off the vestibular nerve in the right ear, but continued to have attacks of vertigo with hearing symptoms on the affected side. No light sensitivity, no sound sensitivity, none of that.
Okay.
So, didn't really favor vestibular migraine.
Yeah.
But because the attacks of vertigo for her was so disabling, and all the treatment measures for Meniere's disease had been exhausted, we decided to try migraine medications instead. This was 3 months ago.
Okay.
Lo and behold, took it all away.
It worked.
Yeah. So
Wow.
a lot of times, you can just treat them as migraine patients because most of the medications are fairly safe, right?
Yeah.
If you have attacks of vertigo that are so disabling, that affect you so badly, you weigh the benefits and the risks. Sometimes the migraine medications could be used. Yeah.
Interesting. Wow, that's amazing. Is it difficult to distinguish an aura of dizziness with vestibular migraine?
So the aura criteria would be between 5 minutes to an hour.
Okay.
And not many patients meet that. So, if you have, the aura has to be between 5 minutes to an hour, and most of my vestibular migraine patients don't have that. It doesn't,
Interesting.
most of them, the dizziness and the vertigo tend to last much longer.
Okay.
And they don't typically have that, aura characteristic where it has to be followed by a headache.
Okay.
Yep.
Interesting.
Yeah. So it's not typically an aura. Like in vestibular migraine, the dizziness, the vertigo, it can occur at any time. In the prodrome, they can occur in the aura phase, the headache phase, the resolution phase, or even in the postdrome. After everything goes away, then the vertigo can hit.
Wow. Okay. Oh, that's really interesting. I'm going to make sure that everyone can hear us okay on here. Can you guys hear us all right? I'm hoping so. I'm guessing if people are still watching, they can. So let me move this just a bit closer. All right. Oh, thank you guys for letting us know. All right.
They can hear.
Yes, they can hear us. Perfect. Thank you, guys. Okay, back to our scheduled programming. We're going to move on to natural treatments. So patients like myself, they often want to try the natural route.
Of course.
Is it possible to get better without medication, and what advice would you give to them?
Definitely. So, there is a role for, quote-unquote natural treatments, right?
Right.
The vitamins, like vitamin B2, magnesium, coenzyme Q10, feverfew, butterbur, all of these can work for migraines. Vitamin D3 as well.
Yeah.
All of these can work for migraines. I think it will depend on the patients. If it's always reasonable to try the vitamins off early to see whether they work or not. Or use it in conjunction with the migraine medications. If they don't, then of course, we can go with pharmacologic treatments.
Okay. Who typically does the best? Do they have some sort of characteristics? Are they maybe having fewer attacks and they do better with natural treatments, or is it completely random?
Generally, I tend to see like those with milder type of disease tend to do a little bit better with the vitamins, the supplements. Those with more severe attacks, more persistent type of attacks, I think because the brain has already entered into that whole very intense cycle of dizziness, being aggravated, and migraines, everything is on fire. Those don't tend to do so well with just supplements.
Okay.
Generally. No.
Okay. Recently, your study was published about using NVNS, which is also known as GammaCore, as an effective natural vestibular migraine treatment. Can you tell me a little bit more about this device and the success you're seeing with your patients?
Sure. So it is non-invasive, so it's put on the skin. It looks like a taser. So it looks like a little taser. You put it on the neck. It lasts for 2 minutes. It stimulates the vagus nerve. The vagus nerve is the nerve that travels from your brainstem to a lot of your organs in the body. It goes to the heart, goes to the lungs, goes to the gut. It has a lot of important functions.
Okay.
So in the brain stem itself, it's connected very intimately with the vestibular system, with the trigeminal system. The trigeminal system is the one that's responsible for migraines.
Yeah.
And the vestibular system, of course, for vertigo. So in the study that I did, it showed that vagus nerve stimulation actually could break the attacks of vestibular migraine, which was very interesting. Unfortunately, because it's been insurance issues, it's very tough to prescribe it to patients. So, you know, I've not been able to put more patients on it, unfortunately.
Just because the cost of it?
The cost of it, and, you know, insurance companies refusing to cover the device. Most unfortunate.
Yeah, that is really unfortunate. I hope it changes one of these days.
Interesting thing though. So UTD has been doing a study in stroke patients.
Okay.
Or in patients with tinnitus, ringing in the ears.
Yeah.
So they have a vagus nerve stimulator as well for that, and they show that it can improve function and improve tinnitus in patients.
Really?
However, it has to be implanted.
Oh.
So it's a minor surgical procedure. Takes about 50 minutes. They open up the neck. Not pleasant.
Yeah.
Right?
Yeah.
But it's not, you know, invasive. From what I understand, you don't have to be under general anesthesia or anything.
Okay.
And the device is implanted inside. That could be one possible method, although, you know, I can foresee not many people wanting to get the device.
Right.
Anyone here willing to do that? Willing to do that?
What about, how is gammaCore different from Cephally? I know you're a big fan of Cephally.
Cephally also has been shown to be pretty good. So Cephally, for those not sure, it's the device that you put on the forehead. So it stimulates the trigeminal nerve. So that's the nerve that innervates this part of the head where it stimulates. It was initially approved for migraine headaches. So, you know, I think the whole theory was they found that first, the patients were reporting that if you have a migraine and then you eat something really cold, you get an ice cream headache, that tends to terminate the migraine. Because both come through the same nerve, so it's kind of like rebooting the computer. So if it's giving you problems, you reboot it, and it terminates any problems.
Okay.
So the Cephally stimulates the trigeminal nerve, and that seems to terminate the headache in some patients. So tested it out in a few of my patients with vertigo. It seemed to work really well. It broke the attacks, and so, you know, because it's more affordable, and you don't have to deal with the insurance companies, you know, I've used it a bit more. So, you know, more patients have been using it. I've had mixed things. So some, I've not analyzed it in great detail as to who did better, how many are doing well on it, how many, you know, not do, you know, didn't find that it's helping. But it seems to, you know, those few of my patients who use it seem to like it. A few stick with it. Yeah.
Okay. Do they like it? Do they prefer it for acute attacks? It sounds like if there's a bad vertigo attack, it seems to work better.
They do it for both.
Preventative and acute. Okay.
Yep.
Okay. What about VRT? It's often debated for vestibular migraine. Have you seen patients be helped by it in your practice?
Personal experience, okay?
And VRT is vestibular therapy.
Vestibular rehab, yeah. So to get you to look at something, move your head around, have an object that moves around, make you focus on it. The goal of VRT is to decrease your brain sensitivity to all those types of things. So if you have a lot of sensitivity with moving your head around, then they will design exercises to help you move your head around more to the point where you become desensitized to it, so you can do it without feeling aggravated. Or if you know, being exposed to certain visual type of stimuli causes you to feel dizzy, then they will expose you to, you know, small amounts of it first and then increase it over time to decrease your sensitivity to it. The problem I see in vestibular migraine patients going to VRT immediately while everything is on fire is that it tends to aggravate it. Because VRT is supposed to make you uncomfortable. It's supposed to, you know, it's kind of like exercise. It makes you uncomfortable, and that way you build up your ability to tolerate more and more and more. And so, you know, if your brain is already, you know, in that whole migraine phase where everything is just aggravating you, it's so too sensitive to everything, going for VRT often makes that worse. What I find is, you know, we starting you off on either, you know, the devices, the supplements or the medication to decrease the sensitivity of the system to put out the fire, to say, that eventually can allow you to go to VRT. Okay. So once the system cools down, if you need VRT to decrease, you know, sensitivity to head movement, to visual stimuli, then perfect. It works really well. But in some patients, you know, it takes it all away, so you don't even have to go to VRT.
Oh, okay. Wow. That's actually really interesting because for me, it was the same case. I was extremely motion sensitive, but we got a lot under control with medications and supplements. But whenever I moved to VRT, it actually helped me on a trip to Vegas to handle all the lights and the movement and everything like that. So I could notice a difference between the past years that I had gone with vestibular migraine.
Excellent.
On the topic of natural treatments, many of us are told to exercise. Why does it sometimes make us more dizzy?
So it will depend on the exercise, right? I typically, for vestibular migraine patients, the exercises that will help with the dizziness would be like yoga, Tai Chi type of exercises, slower type of exercises to, to get you accustomed to moving your head around, maintaining your balance, improving your confidence in balancing, walking. So those are the exercises that will help decrease the dizziness. The ones that tend to aggravate it would be like, if you're running on a treadmill, for example. If you're so sensitive already to motion, to any what we call visual vestibular mismatch, so meaning the information coming from your vision and from your inner ears is different, brain doesn't like that. And so, running on a treadmill, especially if you're looking at a TV, that quite uncomfortable. Getting off the treadmill after using it for some time, having to adapt to the firm surface again, that also is pretty uncomfortable. Or bouncing up and down on an elliptical, that can be uncomfortable. Exercises that require, if you do burpees, for example, jumping up and going on the ground, a lot of this up and down head movement, pretty uncomfortable for vestibular migraine patients as well. I think in initial phase, when everything is super sensitive, I think those exercises are very uncomfortable. But over time, with the medications, with yoga, with Tai Chi, with VRT maybe, then you will be able to tolerate more of those exercises.
More movement. Okay. On to medications. Are there types of medications that you find most effective? Or does it really depend on if your vestibular migraine is maybe comorbid with other disorders?
Everyone is so different.
Okay.
So I tend to choose medications that can perhaps cover more than one problem. So for example, if anxiety is a big problem, then I choose, migraine medications like Effexor or venlafaxine, which has some mood controlling properties as well. If you have high blood pressure, for example, then I perhaps would use a beta blocker. Where you control your blood pressure and also can control the migraines. Generally, people are so different, it's difficult to predict who will respond to which medication. I have patients on so many different things. It's hard to say which medication works best. It's
interesting when I meet other patients of yours, we're all on different paths.
And some may need a combination of different medications. Some need a little bit of this, a little bit of that for optimal control. So.
One thing that worked really well for me and some of my other friends, especially friends who were trying to get pregnant, were Timolol Eyedrops. But a lot of doctors question this prescription because of the small studies or they've never heard of it. What results have you seen in your practice?
So, the studies are small, because again, it's a generic medication, no one is going to invest a lot of money in doing like a full clinical trial into Timolol Eyedrops. The few studies that are out there, show that it was good for breaking migraine attacks. I chose to try it out in patients like, yourself, who, issues with, trying to get pregnant or, cannot tolerate other medications, just pulling everything out there. Let's try everything. I'm willing to try anything. All the medications, whatever it is, the treatments, as long as it's safe, as long as the side effects are not terrible, I'm willing to try them. And so that was the case like with the Cephaly and the Timolol Eyedrops. A lot of the patients tend to do well on them. Of course, there are some that don't really respond to the eye drops. But then again, if anyone tells you a treatment is 100% effective, you should have your doubts. So there's some that do well on it. There's some that don't. I do have I can't remember exactly how many. A fairly good number of patients who just use the eye drops and seem to be pretty happy with them.
Are they using them acutely or preventatively?
Both.
Okay, interesting. Do the new CGRP medications work well for vestibular migraine?
Great question. So far, my experience is yes.
Oh, okay.
Yep, so far it seems to be controlling it well. I do have a few who didn't tolerate it. They've had like local reactions to it.
Yeah.
And then one patient had really bad constipation on one of them. But in general, those who have been using them have found that it really helps.
Interesting.
Yep.
Well, what about, does it take a while to build up in the system, or do they notice results right away? What can you expect?
Generally, I counsel patients, when you will first start seeing benefit will be at about 3 months. And then it takes about up to 6 months for you to realize the maximum benefit. So I always counsel my patients to be, patient with the CGRP inhibitors, keep using them, be patient, as long as there are no bad side effects, as they stay on it. And between 3 and 6 months is when we can really appreciate any benefit.
Do some work differently than others? Like, say, if one doesn't work for you, you could try another, or is it pretty? If you fail one, you might fail the other ones?
We don't know.
Okay.
Yep, so the ones where I've switched between classes are those when they have side effects.
Okay.
When you have side effects with one, then I switch to a different one. I have not tried going from one CGRP inhibitor to another in terms of looking for efficacy changes. That I have not done yet.
Okay.
Yeah.
Or have you thought any more about the ones that are supposed to be taken acutely? Like instead of Triptans.
So you're talking about like Ubrogepant,
yes.
And the latest one that's approved, I think, is Rimagepant. Yep. So it's very early. It just got approved.
Yeah.
Given out a few samples, you're waiting to see.
Okay.
Yep.
What about Triptans for vestibular migraine?
They seem to work well.
Really?
They seem to work quite well.
Okay.
Initially I wasn't sure whether they would work. I thought they would work more on the headache side of things.
Yeah, because I've seen past studies say they don't work at all.
Absolutely. But I've noticed that, the patients using the Triptans, a lot of them actually find that it works.
Wow.
To my surprise.
Okay.
Yep.
Even just for dizziness and
Correct.
vertigo.
Correct.
That's amazing. Yep. Okay. What acute treatments seem to work best? I guess you've kind of explained that with us.
The Triptans, they work well. The eye drops, Timolol Eyedrops seem to work well. Cephali can work as well. Interestingly, sometimes the pain medications like Advil, Tylenol can work in some patients. Not a lot of them, but some it works in some.
Okay.
What other acute treatments do we
What about Benadryl? Do you have success with that still?
Typically, I see patients combining Benadryl with other medications during the migraines, like the quote-unquote migraine cocktail.
Okay.
Yep, so, they'll combine. Usually if you're getting Reglan or metoclopramide, they combine it with Benadryl so that you don't feel so antsy while you take it. Yeah. But Benadryl itself, I'm not sure. I don't have any patients who just pick Benadryl.
Okay, what about benzos?
Benzos work too. Yep, benzos are, kind of a dirty bomb. So they suppress everything.
Yeah.
So, if you're having vertigo from any cause, not specifically migraine, the benzodiazepines work really well too. Okay. They can just calm everything down. The main problem with that would be, of course, the drowsiness that comes from benzodiazepines.
Yes.
Yep. So after you take one, you'll be sleepy, you cannot, function for a period of time.
Okay.
Yep.
How do you feel about Botox for vestibular migraine?
So very early experience in it so far. I have some in whom it works and some in whom it doesn't work.
Okay.
We definitely want to try it more. The biggest hurdle for it, of course, would be, getting insurance approval.
Yes.
Yeah. So, I think they would require a diagnosis of chronic migraine for it to go through. So if we just say vestibular migraine, purely that, it can be tough. But we could, if you have enough headaches, we can make the diagnosis of chronic migraine.
That's interesting. I think it goes back to our first question about vestibular migraine not being labeled as chronic.
Yep.
Huh.
I think the classifications will be useful if there were some medications that are FDA approved for it.
Okay.
I think that's when they'll start splitting hairs and saying, okay, so acute, that's episodic versus chronic. That's what they'll do.
Do you ever think there will be a medication specifically for vestibular migraine?
One day, probably.
Okay.
Yep. I mean, so far there's so much overlap with just migraine headaches that I think we can use medications and treatments for migraine, for vestibular migraine. There may come a day where we see there's one that's specifically for vestibular migraine.
Okay.
Yeah, it is possible.
That would be very exciting.
Yep, absolutely.
It's flu season.
It is.
Do you have any tips to relieve head pressure when flying or having a cold?
So one of the things you can use are the saline rinses, nasal saline rinses.
Okay.
Clears out all the gunk for you. Sometimes you could use oxymetazoline Afrin nose sprays.
Yes.
Those can work as well. You have to be careful with those though. You cannot use them too often, if not you have a tachyphylaxis, and it can cause more congestion instead.
Okay.
So you have to be careful with those.
So maybe just right before a flight or something like that.
Absolutely.
Yeah.
Yep.
What about for a cold? Anything? What about maybe like a steroid treatment or something like that?
I would be careful with those. If you're having
Okay.
like the flu or you're having an infection, I would rather not give you steroids during that time. You want your immune system to be functioning well to fight off the virus.
Interesting.
Especially the coronavirus.
Yeah. We won't talk about that today. But it has dampened our crowds a little bit, so we see you all online.
Virtual meetings are the way
Yes.
to go.
Other vestibular disorders, we'll
Yes.
move on to those. How do you differentiate VM from PPPD, and how do you decide how to diagnose with one or the other or both?
So PPPD is persistent postural perceptual dizziness.
Yeah.
So that one is characterized by more of a constant type of dizziness. Usually it's related to some medical illness or something that gave you really bad vertigo or some very stressful event. And
Okay.
I always draw comparison to PTSD, post-traumatic stress disorder, where you have some traumatic event and then you suffer the consequences of that event, the anxiety, the flashbacks, all related back to that trauma. So in the same way, PPPD is dizziness that arises from some initial events, usually something that gives you vertigo, but it can be a fall, some very stressful event, or some serious medical illness.
Mm-hmm.
And then the brain is left in this state of constant dizziness for a very long period of time. I've seen some patients up to 20 years with the dizziness.
Wow.
Now, vestibular migraine is, going back to the definition, you have episodes, attacks, where you have the vertigo, the dizziness with migraine symptoms. And so what happens if you have both?
Mm-hmm.
So if you have vestibular migraine and PPPD, then you will have the constant dizziness of PPPD, but you also must have the attacks of vestibular migraine. So if you just have the attacks of vertigo with migraine symptoms, then that's clear cut. That's vestibular migraine. Mm-hmm. If you just have dizziness, constant dizziness that doesn't really fluctuate, no attacks with migraine symptoms or migraine features, that's most likely PPPD. Then the tricky part is when you have both.
Right.
So a lot of times, because vestibular migraine can give you vertigo, that also can create PPPD. And so you can have both.
Okay.
Yeah.
Wow. So how do you usually go about diagnosing a patient and
history? So we take a good history. I look for attacks. See if there are attacks of vertigo with migraine symptoms, then we bring in vestibular migraine.
Okay.
If they have more of the constant type of dizziness, that's more PPPD. And then if you have both, you could have both diagnoses together.
So with PPPD, does your dizziness increase at all or decrease? It just stays constant, is kind of what you're making it sound like.
It can increase. So certain stressful events can increase,
Okay.
can increase PPPD's dizziness. But what I look for typically is, do those increases, are they consistent with vestibular migraine or not? Yeah.
Interesting.
If they're not, then it's just PPPD. But if you
Yeah.
have increases, and then if they have like those bad increases, and with those increases they have all the migraine features that come with it, then that points more to vestibular migraine and PPPD together.
Okay.
Yeah.
How do you treat PPPD?
Currently, the treatments are either VRT, vestibular therapy, the benzodiazepines, or the antidepressants. Yeah.
Okay.
Currently, those are the ones that are shown to help. Although there was a study from Europe that showed that the gamma core device could help.
Okay.
PPPD. Yep.
So the moral of the story is we need that to be covered by insurance.
Good luck with that.
Yeah. Next session.
Yep.
What are the differences between vestibular neuritis and vestibular migraine?
So vestibular neuritis is a monophasic event, meaning it just happens once. So you have an attack of vertigo, due to herpes simplex virus reactivation in the vestibular nerve. And so the vertigo can last anywhere from a day to about a week. And you'll have the nausea, the vomiting with that, you'll have the bouncing vision, the oscillopsia that comes with it, and then that settles down.
Okay.
Because your brain learns, okay, there's a difference between the two sides, you shouldn't be spinning all the time. It learns, and then you're left in this period of imbalance that can last, weeks, months, depending on the person, and then once your brain adapts to it, it goes away. Okay. So that's vestibular neuritis. It's only one attack.
Okay.
Yep, because if you're unlucky, you get the other side later on. But it should only cause one attack. Vestibular migraine, however, would cause constant, frequent attacks or recurrent attacks of vertigo rather than one single attack. Like that.
Okay. What is the link between Bppv and vestibular migraine?
No one knows.
No one knows. Okay.
So Bppv is a benign paroxysmal positional vertigo,
yes.
so for our view. So, not to be confused with PPPD, persistent postural perceptual dizziness.
Lots of
I don't know who named it.
abbreviation.
Someone
who's very long-winded.
Yeah. So Bppv, just a quick little thing is because there's a loose crystal in your inner ear, it goes into one of your semicircular canals, and when you move your head in the plane that controls that canal, then the crystal moves and you get a vertigo. So typically with those attacks, it's a little burst of vertigo that happens, lasts less than a minute, and then that goes away. Vestibular migraine can present with positional vertigo.
Mm-hmm.
It's not that common, but it can occur. But the positional vertigo in vestibular migraine typically lasts much longer than that of Bppv.
Okay.
So as long as you maintain your head in that affected position, you still get the vertigo. Whereas with Bppv, if you put your head in that position for a long period of time, it doesn't come back. It's when you shift, you get the burst, and if you keep your head in that position, it'll go away. It doesn't last as long as you maintain your head in that position, usually.
Okay.
The attacks of Bppv usually don't come with migraine symptoms. Whereas with vestibular migraine, if you have positional vertigo, you typically get your migraine symptoms with that as well. So you have the light sensitivity, sound sensitivity, headache, or the visual aura. The link between vestibular migraine and Bppv, no one really knows.
Okay.
Not yet. But there's a link between Bppv and migraine. So more patients with migraine tend to experience Bppv than the general population. No one knows why yet. Yeah.
Oh, wow. Yeah. Okay. What about Meniere's disease? That seems to also be connected to vestibular migraine. Huge
connection with vestibular migraine. So Meniere's disease, there's a huge overlap with vestibular migraine. Meniere's disease typically is referred to as endolymphatic eyedrops, where you have swelling inside in the inner ear, and that swelling causes the ear pressure, and then when it pops, you have the attacks of vertigo with the fluid starts to mix in the inner ear. Very big overlap with migraine and vestibular migraine. So 50% of Meniere's patients have migraine. And a lot of vestibular migraine patients, or rather a lot of Meniere's disease patients, also experience vestibular migraine. To make things even more complicated, the attack of Meniere's disease can trigger a migraine. So it's a very big overlap. To make the diagnosis of Meniere's disease, you need to have documented hearing loss in 1 year at least. Yeah. And it has to be the low frequency type of hearing loss, and that hearing loss should fluctuate. In the absence of such hearing loss, I'm a little bit hesitant to make the diagnosis of Meniere's disease. Yeah. You can have both, for sure.
Yes, okay. Which one do you usually see first? Or do they usually present at the same time?
So vestibular migraines are much more common.
Okay.
Yeah, much more common than Meniere's disease. So your chances of, if you're a physician, the chances of encountering vestibular migraine is much higher than that of Meniere's disease. Meniere's disease tends to occur in the older patient population, generally, a little bit older. Vestibular migraine, a little bit on the younger side.
Okay.
Yeah, generally.
Oh, I remember at first we thought vestibular migraine was usually an older person's
Not as old as Meniere's disease.
Oh, okay.
Yeah, older compared to migraine.
Gotcha. Okay. Why are positional head changes so hard for some people?
It goes back to the whole visual vestibular mismatch. So when you have vertigo, your brain becomes, your brain doesn't like vertigo, it hates vertigo. And so what happens is it tries to ignore the input from the inner ears and begins to rely more on vision.
Okay.
Yeah, and begins to, so most migraine patients or vestibular migraine patients become very visual dependent. And that is why, you don't like the blinds, you don't like the carpet.
You're
because
so tired at the end of the day, yeah.
Because because you're so reliant on your vision for balance, anything that throws it off makes you feel terrible. Yeah. So in the same way, when you become so visually dependent, if you're moving your head around too fast, then that visual input becomes affected. And so, throws you off, makes you feel uncomfortable.
Oh, okay. Well, this is all very informative. Thank you so much. Let's talk a little bit about the future. What are the future directions in research for vestibular migraine?
So many.
Okay, that's
so
good.
There's so many things that can be done still. Looking at treatments for it for sure. Looking at acute treatments. You're looking at preventive treatments for it. Looking at the characteristics of it, its relationship to Meniere's disease, its relationship to regular migraines. There's so much that can be done. So much we don't know about it yet.
Is there anything you're working on that you can share with us?
Working on, let's see. So I'm trying to look back at all my patients, the different treatments that everyone is on.
Yeah.
So a little retrospective review, so that way I can summarize it and, talk to patients, and people can see, these are the treatments that seem to work for patients. These are the treatments that don't seem to work so well. That way that, we can provide some guidance to the clinicians so that, when they are interested in trying a treatment, they can look back and say, oh, this is what seems to work, this doesn't seem to work so well. Another one that I'm looking at is, there's a condition called MDDS.
Oh, yes.
Yep. So its relationship to vestibular migraine. I do have a group of patients with it and vestibular migraine, trying to see, what the characteristics are, how patients with MDDS and vestibular migraine are different perhaps from those with just MDDS alone.
Okay, so they can be comorbid too?
Definitely.
Wow.
It's like my old mentor used to say. Some dogs have ticks, some dogs have fleas, some dogs have ticks and fleas.
Okay.
No.
Very unlucky dogs.
Unlucky indeed. No. So, just having one disorder doesn't mean you cannot have another problem.
Okay.
Yeah.
MDDS isn't very well studied, is it?
Correct. It's not as common, it's somewhat rare. But it's a very interesting condition.
Yes, very interesting. Do you see it more in people who travel a lot?
Generally, yes. So, most cases are triggered by some form of travel.
Okay. Is it easier to see patients get better with MDDS, or is it just as hard to treat as vestibular migraine?
Personal experience.
Okay.
Now, haven't analyzed the data properly yet, but
don't hold them to it.
Personal experience. Those MDDS patients with vestibular migraine seem to do better than just MDDS alone.
Okay.
Generally, yeah. So,
wow. Interesting. Okay. Can migraine be cured? I know the answer. But one of the most wonderful things you ever said to me in an appointment was that remission was totally possible. You have many patients who have found it.
Absolutely. It cannot be cured, unfortunately. It's in your genes, but it can definitely be controlled. If you think of it like high blood pressure, right? So that one, there's no cure for it, but as long as you're on the proper treatments, it can stay under control. Now, the difference with high blood pressure is that, migraines, they seem to get better after a period of time. So there are patients who can wean off their medications and continue to do really well, whereas you can't do that with high blood pressure in general.
Okay. Does it often depend on life events? Like I wean off my medications, but I'm a little worried about pregnancy. Can it ebb and flow?
Definitely. So migraines, definitely are affected by life events. Hormonal changes, with pregnancy can affect it. Okay. Any unusual form of stress. So, if something really bad happens, that can cause the migraines to flare up.
Right.
Weather changes can do it too. So, if you're unlucky, if you're ill, you're undergoing some form of stress and the weather changes at the same time, that could cause the migraines to flare up again for sure.
When that happens, do you typically go back to what worked for patients previously, or do you try something new? Usually
we go back to the same medications. If that doesn't work, then we have to try something new.
Yeah, okay. How does one tackle when that happens again without getting too discouraged?
The good thing is, you have to understand. You understand what you're going through, right? You really understand the problem. You don't have to repeat everything all over again, go and try to figure out the diagnosis. And so, I think that makes it a little easier. You can start the treatment off and, see if it works.
Okay. Do you often see that happen with patients, or once they go into remission, are they pretty stable?
Sometimes it happens, yeah.
Okay.
Sometimes it can flare up again, for sure.
Huh.
Yeah.
Well, what's the number one thing that seems to help your patients the most?
Most important thing, I know it's going to sound cliche, but it's attitude.
Yeah?
Yeah. So attitude is very important. Understanding the condition, is part of it, but keeping an open mind about treatment is so important. Those that tend to shortchange themselves, I notice, are those who, just say, nothing will work, no medication will work for me, or those who don't want to accept the diagnosis of vestibular migraine. I've had some who refuse to accept that diagnosis because of the lack of headache. Then they refuse to believe that they have vestibular migraine. So being open to things. So having an open attitude to things. Learning more about the disease, learning more about treatments. Be willing to try things.
Yeah.
To see if anything works for you, and not just discounting things, ruling things out, I think that's important. Other things too, when it comes to attitude is also, how you respond to life in general. If your response to stress is also very, very important. Stress is the biggest trigger for migraines. Number one trigger for migraines and vestibular migraines.
Wow.
And so, how you respond to stressful events is also important. Stress management, it's where that comes in. No one can avoid stress.
Right.
Part of life. But how you respond to stress, that's what you can control. And so, if you, can control how you respond to stress, that can also control, how bad your migraines will get or not.
Okay. As you were saying, patients have to be open-minded.
Yep.
What if their doctors are not?
Unfortunately, if they're, and that happens a lot. So, I've encountered neurologists or other physicians who don't believe in the diagnosis.
Yeah.
Then, you will have to find somebody that, is willing to work with you.
Okay.
Yeah.
So just shop around, I guess.
Yep. Shopping around. It's not such a good term. They usually reserve that for those looking for pain medications.
Gotcha.
But looking around, I think it's also important. If you find a doctor that you can work with.
Okay.
You can't work. Not everyone is compatible 100%. With you. So you can, if you find a physician who's willing to work with you, who's willing to try different medications and monitor and see what's going on. That's important.
Okay. How do you have any advice to get out of that bad attitude when you just feel like nothing is working and you're just beat down? I see that so often, even with my readers. Yep. They've been trying everything.
The one thing, the good thing is, that they are following you, they talk to you. I'm sure they talk with each other.
Yeah.
First thing is to, to realize that can be a problem, that, you mustn't try and shortchange yourself. You have to take care of yourself. You have to, be willing to dedicate you that energy, be willing to put in the effort into taking care of yourself, taking care of your health. It's not, you have to realize that, you cannot just sit back and, just be defeated by the disease and just say, throw your hands up and say, okay, Sarah.
Yeah.
Right? You have to, try and work at it, find somebody, who can work with you with the, to try and guide you a little bit. A lot of medications are prescription, a lot of treatments are prescription only. And so, finding a clinician who is willing to work with you is also very important.
Yeah.
Yep.
So there's no end to the amount of treatments you can try, right? When people say they've tried everything, there's always a different combination, you're saying.
That's true. That's true.
Yeah.
I mean, there are a finite amount of medications, right?
Yeah.
But as long as, we're willing to try things, we can always do it. Yep.
Okay.
Yep. The different medications, everything can be tried. As long as it's safe.
Yes.
Yep.
Does anyone else have any questions that are here? Okay.
So you talked a lot about in diagnosing patients, history is really important.
Absolutely.
What parts of their history are you looking for, and what parts of history should your current patients, keep track of?
Great question. So you need to tell me, when I first see you, I want to understand what you mean when you say you're dizzy, what you mean when you say you have vertigo. So not everyone means the same thing when they use those terms. So it's very important to me to understand what you mean. So be prepared to, explain exactly what you mean. Is it spinning, tumbling, falling, floating, shimmering, any of them? You have to explain it to me so I understand. You may have more than one type of dizziness, and so going back to if you have more than one type of condition, and so you also need to understand that first. Do I have this, and do I have this? Do I have this most of the time, and this from time to time? So I need to understand that. You also need to tell me what other symptoms come with them. And so, does your hearing change? Does your vision change in any way? Do you get a headache with it? Do you become light sensitive, sound sensitive, sensitive to smells, any of that? I also need to know how often they happen, and of course, very importantly, triggers. Yeah. So, if you have an attacks of vertigo, for example, are they triggered by something? And you need to tell me what those triggers are. So a good way to do it is to keep like a little journal, like a day planner. If you have vertigo on the day, write down that you had vertigo. If you have any other symptoms that came with it, write it down. If you think that could have been a potential trigger, write it down. Maybe you ate something different, you didn't eat, you slept too much, didn't sleep enough, or the weather changed that day, some unusual form of stress, coronavirus, something like that. So keeping a little journal is important.
So even those symptoms we think are so weird that you might think are weird, we need to tell you those.
Absolutely. I ask for the weirdest stuff.
What's the weirdest one you've ever heard?
So there are weird ones like, we wrote a paper on what we call Alice in Wonderland syndrome.
Yeah.
So Alice in Wonderland syndrome is a usually migraine-related phenomenon where, kind of like Alice, you can either feel as if you grow too big, you grow too small, objects appear larger than they are, smaller than they are, further away, closer, or some unusual experiences where you feel as if you've left your body, you're floating outside your body, things don't become real around you. Some rare ones where you feel as if time is moving slower than it should be, moving faster than it should be. Certain body parts apparently go missing, or certain body parts feel larger, smaller than they should be. Very unusual stuff, but important.
Yeah, it's crazy that that's a migraine symptom.
Absolutely. Migraines are fascinating. Endlessly.
Well, I'm glad you think so.
To me, at least.
Does anyone else have any questions?
I do.
Dr.
Beh, I'm not currently a patient of yours, but I hope to be soon.
Be patient.
While I'm on your waiting list, what are things
Call
I
for
can
cancellations.
Call for cancellations.
Very important. So there are usually cancellations, so just call.
I will do that. I'll for sure do that. In the meantime, any suggestions on what I can do? Vestibular migraine is a fairly new concept to me.
So legally I cannot give you any medical advice until I form a therapeutic relationship with you, right?
Yes.
So, when I first see you, then we have to discuss whether you really have vestibular migraine or not. So we'll go through your history, we'll figure that out together, and then if you do, then we'll discuss the treatments. You can, treatments for, the supplements that you can take for migraines in general. You have vitamin B2, magnesium, coenzyme Q10, Bppv. Bppv, you have to be careful of the brand. There are some brands that contain an alkaloid. It can be harmful to the liver, so you have to look that up. Feverfew, vitamin D3. So those are some of the vitamins that could potentially be very helpful for migraines. So if you want, you can go try that out first before you see me.
Sure.
Yep.
Thank you.
Everything you said is right.
No.
Maybe we'll take one or two
I try
questions
not
from
to
online.
give fake news.
That's good.
Does anyone have any questions that they would like answer? We'll take one or two. Let me see. Oh, I wish he was my doctor.
Thank you.
No one? Oh, here we go. Just submit them really quick if you have them. We still have them for another 5 minutes. Let me see.
I have one while we're waiting.
Go for it.
Oh,
No, you go ahead first.
a couple months ago, I was listening to a radio show in Tulsa, and they were talking about prolotherapy.
What's that?
Is that something you can use? Well, it sounds like what they do is they inject either saline or lidocaine, and they do like a nerve block. And they were talking about doing it under the scapula, in a nerve under the scapula. But it's not like stellate ganglion block. Some of them do that, and it's used for PTSD.
Is it for, it's just for PTSD and not for pain?
It's for people who have anxiety and high stress.
I have not heard of that one so far.
Oh, well,
That's
they were just
interesting.
talking about a new, they were saying how effective it was, but they were mainly talking about it in relation to people who have had trauma, some kind of traumatic experience, but
Interesting.
really any kind of stress.
Oh,
And they were
very
saying
interesting. I've done some nerve blocks for people who have occipital neuralgia. So those are when the occipital nerve is kind of inflamed, and then what you do is inject a little bit of lidocaine around that. So because the pain from that can also cause their migraines to flare up or cause a lot of headaches, problems with that. The nerve blocks or injections into the neck can work for those patients with bad dizziness who've basically kept their head like so rigid to the point that it's causing neck problems and shoulder problems. Then it's helpful there.
Is that the cervical? Is that the cervical migraine thing?
I don't. So you can do the blocks, the trigger points. If you've become so stiff from not turning, you want to move your head around, so you stiffen up so much that the neck starts to hurt.
Yes.
Then sometimes nerve blocks in the neck can work too. Yeah.
Can people hear me say this if I talk?
I have no idea.
Well, I just want to be on the hopeful side
Of course.
things.
Yep.
I don't know if anybody can hear me on there, but just whoever's watching, I just want to say thank you for being a doctor to so many of us who literally have had vertigo like myself for almost since 1997, and going through many trials and tribulations and different doctors and seeing various people. I don't know who's listening to this, but you have been incredible.
Pleasure. Thank you.
So you have been so extensively kind, so detail-oriented. I mean, thank you for everything.
Pleasure.
And just whoever is out there that is losing hope, please see Dr. Beh, because, I mean, really, he has helped me. I mean, I'm still on my journey. I'm not 100% what I want to be, but if I could just say that Dr. Beh is incredible. So he is worth the trip, whoever flies.
He is worth flying to.
Whoever the
Yes.
coronavirus, whatever
Yeah.
that passes, I just want to say that thank you for that. And it does get better.
Yep.
You just have to work at it. And just like he said earlier, we're not one size fits all of people. But anyway,
Yep.
I think you've said a lot. I mean, there's a lot of questions with hormones that I have with
Actually, we got that, so maybe we can answer that.
Tell us what the relationship with Felicia, she's on her path, but like me heading into perimenopausal phase and all of that, what does that really, to me right now, has exasperated some of my symptoms even more. And I guess talk about that, the relationship.
So migraines and
that.
hormones, they go hand in hand. That's why a lot of times, the menstrual cycle is a trigger for the migraine. Some people get it leading up to the migraine, some people after it starts, they get the migraine. So huge thing there. To talk about pregnancy, most of the time migraines tend to get better during pregnancy, and then after pregnancy they flare up like crazy. So hormones play a huge role. When it comes to vestibular migraines, it's very interesting. So patients tend to have regular migraine headaches early on in life, and then as the menopausal changes come in, the headaches tend to get better. Sometimes the headaches go away completely. Sometimes. Generally, right? Generally. Yep. They tend to go away, but then the vertigo and the dizziness tends to kick in after that, usually. Now, we don't know about patients who start off young with vestibular migraine prior to menopause, how it will change with the menopause. Does it get worse? Does it get better? No one knows. No one has looked at that yet. And so, hormones play a huge role in it. Going back to your question about hormone replacement, it's important to talk to your OB-GYN for sure. If, and I can't keep up with the changes all the time with, hormone replacement. One moment it's good, one moment it's bad. One moment it causes cardiovascular issues, one moment not. One moment strokes, one moment not. So I can't keep up with it. But it's important to talk to your OB-GYN. And if you don't have any risk factors, to be on hormone replacement, and I think it's very reasonable. If you find that things are changing with the menopause, and they agree that hormone replacement is a safe option for you, for sure, go for it.
What about birth control? Do you recommend patients be on it, or?
They can, yes.
Okay.
So if you find that you have a lot of attacks around the time of your period, then you can go on birth control to try and reduce them.
Okay.
Yep.
Do you find that patients who are pregnant, have babies, they flare a little bit? How do they get back into being treated again?
So we have to start you. So usually if you're in the midst of a lot of attacks, I can give you a burst of steroids.
Okay.
Maybe put you on a little bit of benzos. After delivering, it can be tough because some of the medications are secreted in the breast milk.
Yeah.
So like the prednisone is okay. That one is pretty safe. So you think for a few hours you're not supposed to breastfeed.
Yeah.
But after that, it's out of your system. You can. Medications like the benzos, some go into the breast milk. Depending on which one, you may have to not breastfeed for a period of time after taking certain benzos. Yeah.
Okay. Yeah, I know you recommend some over others for those.
Correct. So you may be able to go with the Cephali. Cephali could work. The eye drops could potentially work. If you are lucky enough and get the gamma core could work too. In the future, hopefully we can find other non-pharmacologic ways of treating migraine. And so that will also, get around the whole issue with pregnancy, harming the baby, with breastfeeding and all of that. Yeah.
Okay. Well, that actually leads into another question we got online, and I saw a few questions that were already answered in our program, so people can go back and kind of scroll back through those. I think you'll find some of your questions. But one we didn't talk about was acupuncture and chiropractic.
So acupuncture works well. The trouble would be finding the person that can do it properly.
Yes.
Everyone is so different. The experiences are so different.
Didn't work for me.
Yep.
Yeah.
So it's, it can also, like if you talk about dry needling.
Yeah.
So dry needling can work which is basically like acupuncture done by physical therapy. That can work for headaches or people with neck pain, things like that. That can work. For dizziness, I have some patients in whom acupuncture works and some they don't. I think it'll depend on the practitioner, where they insert the pins or the needles, not pins, needles. Where they insert the needles and, all of that. I don't know if there's like a uniform way for them to perform acupuncture. Like if you're dizzy, these are the spots you must put in.
Okay.
If you're having, headaches, these are the spots. So I'm not sure about that.
Okay.
Yeah.
I mean, some people have talked to me about upper cervical chiropractic care. Is that something you have patients do, or?
No studies to show whether it works or not. I know I've read some people it has worked in, some people not. You have to be a bit careful.
Yeah.
I would be hesitant to let anyone mess with my upper C-spine because it's very close to your brain. It could work. I would avoid, generally if my patients ask about chiropractors, I would usually advise them to avoid the ballistic type of movements.
Yes.
Those, the neck snapping and cracking, because there's a risk that you could tear one of the arteries and cause a stroke. So if it's like massage, little gentle manipulation, no harm trying that.
Yeah. Okay. And then we also got a question about the Heal Your Headache diet and migraine diets in general.
Absolutely.
I know they work for some of your patients, myself included. What do you usually see?
Read her cookbook. No. So the Heal Your Headache, I think, is pretty strict, the diet.
It is strict, yes.
You have to avoid a lot of foods. It's very individual, I find. Not everyone, for example, is sensitive to chocolate. A lot of people are, but not everyone is. Caffeine, some people cannot even tolerate 1 cup. Some people can drink 1 cup a day. Some people drink it with impunity and have no problem. But generally, I think the big ones are like MSG, caffeine, chocolate, red wine, aged cheeses, the cured meats. So avoiding all of those can potentially be helpful. I would say keep a diary. So
Yeah.
you know, keep your little journal. See, you know, if you eat a particular type of food and it causes you to have your vertigo attack or your migraine attack consistently, then you know you want to avoid that particular food. Or you could, if you go on, you know, the heal your headache diet and go off everything completely. If you want to try reintroducing food items, you know, one by one to see whether they cause a migraine or not, you can try that.
Yeah. Okay. What about keto? That's very popular right now.
Very interesting.
Yeah.
Well, so it could help. It could potentially help. It's a tough diet to stick to.
Yeah.
But it could potentially help. I would say initially it could aggravate your migraines though. Now, that's just theoretical. Right?
Interesting.
Theoretically, it could aggravate your migraines because, you know, missing meals is a trigger for migraines.
Yeah.
So if you go on the keto diet, you know, you are eliminating carbs from your diet completely. That period where you're shifting from metabolizing glucose to metabolizing fat may be uncomfortable for your brain. And you could have more migraines during that, you know, transition period, possibly, you know.
Okay. I expected you to say it was because you're eating more aged cheeses. Or
That could be. I mean, if you avoid those, avoid the sausages, the bacon.
Yeah.
Yep. But interesting that, you know, if anyone has experience on the keto diet helping migraines, you know,
Go ahead.
tell us more.
Okay. One last question we got was, does PPPD ever go away?
Yes. Most of my patients, it goes away.
Okay.
Yep. Getting on the right medication, you know, usually gets rid of it.
Yeah,
Yep.
I think that's the moral of the story for this whole session is a lot of the stuff can go away.
Yep. If dizziness, vertigo, most of it can be treated. Yep.
Perfect. Well, thank
Vast
you for
majority.
giving us hope.
Pleasure. Always good. Hope is very important.
Well, we greatly appreciate your time.
Pleasure.
Tonight was thanks to Miles for Migraine for putting this on, as well as Tiva for sponsoring the event for us. We're really appreciative of that, and we have quite a few people watching.
Excellent.
So
avoiding the virus.
Avoiding the virus, and we'll just give each other waves. Bye, guys. Thank you for joining.